Now, our next session is on prostate imaging, and the person who is giving that talk is Dr. Daniel Margolis. Dr. Margolis is the professor of abdominal imaging, and he leads a ton of research projects for prostate cancer imaging with MRI and other forms of imaging at Weill Cornell University in New York. He has been a longtime friend to me personally. I have learned so much from him. But one of the things I love about Dr. Margolis is his demeanor. He is so kind and so caring, and he is just one of those people where when you see him talk to patients, he just answers their questions. He really, truly cares. And not only does he care, but he is so incredibly invested in prostate MRI. He's done over 100 publications in those different areas, and we really appreciate that he came out to California to be with us and give this presentation. Again, I would encourage you to come next year, because when you get to interact with these experts, it's a great way to get your questions answered in person. So what you're about to see is a presentation that Dr. Margolis gave and his Q&A with Dr. Moyad, and then right after his Q&A with Dr. Moyad, he went to the patient Q&A session where they had a press conference style, and the patients were able to answer their questions in person with him. So if you would like to have that kind of experience again with the speaker, again, sign up for our next conference in September. But without further ado, here is Dr. Margolis' talk.
Thank you, everyone. So Dr. Roach is a really impressive speaker, very engaging. I'm used to working in a dark room the whole time, so I'm going to use the podium. But thank you all for coming. I have the pleasure of talking to you on prostate cancer imaging, where we are and where we're going. One little erratum, I'm now full professor, so there's that. Yeah, thank you. All right. So again, also unlike the esteemed Dr. Roach, I'm kind of easygoing when it's come to working with other companies. So I have the benefit of working with a number of other companies trying to improve what they're doing in terms of prostate cancer imaging. And then you'll see why it's important that Scott Reeder and I were housemates a while ago. So let's think about where we are and also how we got here. So some of you might recognize what this is. This is what we call magnetic resonance spectroscopic imaging. So it's a graph of the concentration of various chemicals in the prostate. And 25 years ago, this was how we would use MRI to determine whether or not something in the prostate was cancer or not. So without even having an image, we were looking at chemical concentrations. So how do we assess the prostate now? Well, we're using a little bit of AI. So we don't actually use Gemini for analyzing MR, but it's coming. And so that's where we are now, where we're going. I wanted to talk a little bit about how we got here in terms of prostate MRI using initial detection as a paradigm. So this is the recommendation from the National Comprehensive Cancer Institute. And here is where they were recommending targeted biopsy after the untargeted systematic biopsies were proven to be negative. And so I'll bring this to your attention. This was less than a decade ago. And you'll see that at the far right of the slide, we were only really considering an MRI and targeted biopsy after a round of negative regular biopsies. So a few years later, we had some level 1 evidence from, the PIRADS committee had established PIRADS, and there was a number of single center trials that showed that it looked like MRI was promising. And so by 2019, they revised their recommendations to consider an MRI after an elevated PSA before we did actual biopsies to consider targeting. And so that brings us to last year. So you can see last year the recommendations are to strongly consider an MRI in the face of an elevated PSA and to strongly consider targeted biopsies based on now overwhelming level 1 evidence. So the new recommendations are to consider MRI as a first step. And I mention this because what we've seen in less than a decade is a sea change in how we think about managing prostate cancer in terms of imaging. And that's kind of going to be a theme about where we are, that we've seen a lot of how we manage prostate cancer, both for the initial detection and follow-up, is now based on imaging. This raises the question, so this was for our standard MRI that uses contrast. Do we still need to use contrast? There's a new concept or an emerging concept of biparametric MRI, which is only the non-contrast components, the T2-weighted imaging and diffusion-weighted imaging components. Has a lot of advantages. It's much faster, but this means that you need a more powerful scanner, and there are some potential issues. So there are more cases where it's equivocal. It has more issues if there are things that compromise image quality, like hip replacements, and also it requires more experience to be able to read an MRI with less information. But we think that it will be equivalent for the detection of untreated cancer. And in fact, at the AUA meeting this year, a colleague of mine from the University College London presented our preliminary findings. So we at Cornell were part of an international multi-center trial that showed equivalent detection. And so this is very promising for the initial detection of prostate cancer. But how this affects subsequent cancer detection, I'll mention in a moment. And that also raises the question, well, do we know if contrast is safe? And so in 2018, the FDA issued some new class warnings. And so we're supposed to provide information the first time a patient receives a gadolinium-based contrast agent. And so we've had some time to look at the history. And so this AJR, American Journal of Röntgenology, is our premier clinical journal for radiology. You'll see the senior author is Scott Reeder, my former housemate, so little disclosure there. The most common risk of this contrast agent is allergy, but it's not the same as with CT contrast, and in fact, the rate of allergy is much, much lower. And there was a significant risk of a disease called nephrogenic systemic fibrosis, which is a connective tissue disorder, but we only saw that in patients with severe renal failure, so basically on dialysis or very close to needing dialysis. And our newer contrast agents are safe enough that we no longer see this. And probably the most concerning thing is we know that the gadolinium ion is deposited in the basal ganglia, which is part of the brain. So we can see this on MR scans. But we've looked at millions and millions of cases of patients who have received contrast with comparator patients that have the same disease profile but did not get contrast, and there's no neurological difference. So as far as we can tell, it's just like any other environmental exposure. We can measure it, but it has no significant outcome. This also raises a question. So MR for initial detection has been proven. What about PSMA PET? And we are gaining information about PSMA PET. We do have some information about PET for cases where MR is equivocal or non-diagnostic. But we're still getting information for the initial detection of prostate cancer. I think that it has been shown to be very promising, but we don't have guidelines for how to integrate it yet. So this brings us to our current reporting standards for MRI. So you've probably heard of PIRADS. I was fortunate to have been on the committee that established this, the Prostate Imaging and Reporting and Data Systems. It's now up to version 2.1. You can see that's the sort of middle article there. And this provides a standardized framework for how we perform MRI, how we read the MRI, and how we report the MRI for the initial detection of prostate cancer. But we've also realized that there are many scenarios in addition to the initial detection where MR can be useful. And that's why there's all these other articles. So for the case of a patient who's had radiation therapy or surgery, for patients on active surveillance, for patients with advanced disease. So we now have a number of different systems. And I'll show you some examples of those and why our systems vary compared to PIRADS. So this is our post-treatment assessment for radiation therapy and surgery. We call it PIRR. It was published by my colleague Valeria Panebianco from Rome in 2021. And you might remember that Dr. Roach mentioned that it's important to know where the original cancer was. And we actually factor that into determining how suspicious the MRI is. So the most important component of post-treatment imaging is, in fact, the contrast-enhanced component. And I'll show you some examples of why that is. So this is a set of images from a patient who's had a prostatectomy. So you see in the upper left, this is what we call our T2-weighted image or our anatomic image. And if you look at the bottom left side of the image, which is the patient's right side, there's an area that's kind of hard to make out, but it's a sort of a dark gray area. If you look at the image at the upper right, you can see there's an arrow pointing to an area that's kind of dark. It's also kind of hard to make out. But if you look at the two images on the bottom right is our diffusion-weighted image, and the bottom left is our dynamic contrast image. And here it's very clear to see that there is an abnormality in its focal. And so knowing whether or not this is at the site of the original cancer is helpful. When it's so clear-cut like this, where all of the components are abnormal, we can be very certain that in this case, unfortunately, there is likely recurrence. And here's another case where we see a lot of the similar findings. So there's a little bit of abnormality on the T2-weighted image that's at the bottom left, and the apparent diffusion coefficient and diffusion-weighted imaging on the top. You can see an area that's a little bit abnormal. But again, the dynamic contrast image really shows convincingly where the tumor is. And if you look at the bottom right, this is a PSMA PET scan. And so the very bright thing in the middle of the image, that's the urinary bladder. Dr. Roach was talking about how the PSMA radioisotope is excreted into urine. And it can make evaluating the bladder and the area around the bladder very difficult. So an experienced reader will see that there's a little outpouching that's not something we expect to see in the bladder. But because we have the concordant MRI, the same findings on the MRI, this helps us confirm that this is a recurrent tumor and not something like an outpouching from the bladder itself. And this is an example where, again, the contrast is so important. So if you look at the images at the top, on our upper left, the arrow is pointing to an area that's a little bit dark on the ADC and a little bit bright on the DWI. So that's concerning. But these kinds of images are very vulnerable to what we call susceptibility artifact or quality issues. When you look at the bottom images, we don't see anything that looks as suspicious on the T2-weighted image. And then that first image in the middle, that's the early enhancement image. And we don't see any enhancement there. We only see enhancement later on. And that's a finding that we commonly see with inflammation. So the MR is suggesting that this is probably not recurrence. But we have the PSMA PET in this case to confirm that. So this is an area where the diffusion is somewhat confusing, and because we have the dynamic contrast, we're able to reassure our colleagues that this is probably not recurrence. And this is another example which shows basically the same thing, where there's no significant PSMA uptake, and there's only late enhancement. But it's important to consider all of the information on the image. So this is that same patient. And what the arrow is pointing to here is a lymph node that's posterior to where the prostate used to be. Now on DWI, we can see that it's large, but we don't actually have a good way of distinguishing inflammatory lymph nodes, which you can see after surgery, versus metastatic disease. On the PSMA PET, though, you can see that it's very bright where that lymph node is. And so this is one of the advantages of combining MRI with PSMA PET. The MR is very accurate for determining where lymph nodes are, but it can't tell whether they're involved. PSMA, as you know, is excreted into urine, and sometimes it can be very confusing to know whether something is the normal flow of urine through the ureter, which connects the kidney to the bladder, or whether it's a lymph node. And by combining these two modalities, we can be very confident about this diagnosis. So radiation therapy, just heard a really excellent talk about that. We use a lot of the same components. So again, we see T2-weighted image at the upper left. The appearance on T2-weighted imaging after radiation therapy is very confusing because radiation causes changes in the prostate that look like cancer, basically. We can't easily distinguish recurrent cancer from normal radiation change on T2-weighted imaging. It's still useful for determining where the prostate is and the size, but unfortunately, the T2-weighted images are no longer useful. Diffusion-weighted imaging also can be very confusing. So if you look at the images on the bottom, the one on our bottom right, it's very clear that there's something that's focally abnormal. The one on the bottom left, you can see a lot of dark areas throughout the prostate. And so that can also be confusing because we want to see an area that's bright on diffusion-weighted imaging and dark on the apparent diffusion coefficient map, and the apparent diffusion coefficient map becomes very confusing. But again, the dynamic contrast is the thing that sort of saves us because that's the only area that's focally abnormal on the perfusion or dynamic contrast imaging. So here are some examples with the associated PSMA PET. So this is the same patient, but two different levels of the prostate. So the images across the top are actually at the top of the prostate, and the images across the bottom are sort of towards the bottom of the prostate. And what the arrows are pointing at across the top is an area that's sort of medium suspicion, or what we call equivocal suspicion. And importantly, what you see is that where the arrow is on the second to the left, which is the ADC map, it's not as dark as some other areas. It is bright on the diffusion-weighted imaging next to it, but on the sort of color-coded perfusion map, there's no abnormal enhancement. And on the PSMA PET, you can see that there's this uniform low-level activity throughout the prostate. So that's low suspicion. The images across the bottom show something slightly different. So again, the T2-weighted imaging, very hard to interpret. The diffusion-weighted imaging also very patchy. There's not an area that's focally abnormal, but we have that focal area of abnormal enhancement, and that corresponds to an area of very bright radiotracer activity on the PET. So that helps us identify that this is the area of the site of recurrence. Now, the reason I've sort of color-coded the outline of these images is the three images across the top that have green, this is before treatment, and then the images that are color-coded with the red is after treatment. And this is an area where, again, we see that the PSMA PET helps identify the area of recurrence, but also it's most conspicuous, most visible on the dynamic contrast, which is sort of the second to the left at the bottom. So using both MRI and PSMA PET can be very helpful for determining whether there's recurrence. Currently, PSMA PET has become so useful that it's usually the first test that we do when there's a concern for advanced disease, meaning metastatic disease, or recurrent disease. But when the PSMA PET is unclear, MRI can be very helpful to identify things like suspicious areas in the prostate or abnormal lymph nodes. So this is another example where, again, we see that there's restricted diffusion, there's not abnormal enhancement, but there is abnormal uptake on PSMA PET. And so this is a false negative case on the dynamic contrast, which is one reason why we often do both imaging tests. This is another example where The seminal vesicles, which are those things that kind of look like ears that go off the top of the prostate, it's where they store the prostatic fluid. That's unfortunately a common site for local metastatic disease. And both MRI and PSMA PET can be very helpful. Again, PSMA PET has the potential issue that these lie near the bladder, and that can be confusing. And that brings me to one of the newer treatment modalities. So focal therapy is where we only treat where we think the tumor is. This is still generally considered experimental. It's not widely accepted as the standard of care. We do this at Cornell, and my colleagues at UCLA do this as part of clinical trials. So because we are still learning how to manage patients that undergo focal therapy, it's important that we enroll them in a clinical trial and have intense follow-up, because we know that there is a reasonable chance that they can either recur at the treatment site, because we're still learning how best to treat it, or that a cancer can develop in another part of the prostate, because we're not treating the rest of the prostate. When you cut it out, there's no more prostate in the patient to get cancer, and when you use radiation therapy, you treat the entire prostate. But because this is a heavily researched area, we now have two different systems for evaluating the prostate after treatment. This makes it a little confusing because there's the assessment systems are different. I'm actually part of a committee that's trying to figure out what's the right answer for this. So again, part of the reason why it's experimental is we don't have consensus on how to evaluate the patient after treatment. And here's an example where the green arrow is pointing to an area that is successfully treated with focal therapy. And so importantly, you see that it's dark on the T2, it's dark on the ADC, it's also dark on diffusion and dark on dynamic contrast. So that's a good thing. The red arrow is pointing to the recurrence, which is dark on T2, dark on ADC, but bright on diffusion-weighted imaging, and importantly, it's the only area that's bright on dynamic contrast. So for focal therapy as well, contrast is crucial. And that brings me to where are we going? This was actually a slide I showed last year. Not all the articles were published at the end of 2023, so that's why some of the lines are going down. The other thing to keep in mind is if you look at the numbers on the y-axis, on the left side of the graph, you'll notice that this is what we call an exponential graph. So it goes 0, 10, 100, 1,000. So going up a little bit means a lot more articles. And if you look at what articles are common now, we're still seeing an increase in articles on prostate MRI. We're seeing a marked increase on articles on PSMA, almost as many as we see on prostate MR. The use of MR for biopsy is still very popular. But the next most popular line is artificial intelligence. And I think because we see so much potential value in our ability to analyze these images in a more complex and sophisticated way, it's gaining a lot of attention. So in terms of PSMA literature, even though it's now clinically approved, there's still a lot of interest in it. Both for the pre-treatment, for the detection phase, as I mentioned, that we still don't understand when and how to use it, but also in treated disease, either for determining the extent of disease, also for treatment planning. And we see what we call the positive predictive value is very high for patients with new disease and also for recurrent disease. There are still some potential drawbacks. So there can be false positive things. It turns out the S in PSMA is supposed to stand for specific, and that's not as true as we had hoped. So we're still learning how to figure out when to call a true positive and when not to. We are seeing that it's changing the way we treat these things. So that little triangle that's delta, that's a scientific symbol for change. And so what we see is that it changes our measured stage in almost 40% of patients. And it changes the treatment in about 22% of patients when looking at planning initial therapy. And there have been some articles that suggest that it's actually better than MRI for many of these cases. And I think that's probably true. MRI is still a very efficient and accurate modality for the initial detection of prostate cancer, and it's very helpful for combining with PSMA to evaluate treatment. And one other thing I wanted to mention is this was a comment I placed in LinkedIn because this is one of the seminal papers on PSMA, but it wasn't published in a radiology journal. It was published in the Journal of the American Medical Association. And what that shows is this is so crucial to management. It's gone beyond people that use it for imaging alone. It's really part of how we manage patients now. And I also wanted to mention PSMA theranostics. So theranostics is a combination of imaging and treatment. And so what we do is take the PSMA molecule, but we combine it with something that not only allows us to image, but will actually kill cancer. And so this first image, you see a lot of areas in this patient that are positive on the PSMA PET scan, suggesting widely metastatic disease. So we give PSMA that's bound to a lethal radioactive component. And then this is imaging afterwards. And so you can see that there are still areas that are positive, but these are normal areas for the most part. There are still some sites of metastasis, but a lot of them have been treated. Now, how this affects long-term outcome is unclear. Unfortunately, we are seeing a lot of patients that have an initial very good response, but it's not prolonged. So we're still trying to figure out what is the best way to use PSMA as a theranostic agent. And then AI is very popular. The list of popular articles in the middle, you'll notice that's from 2021, 2022. And the list on our right is from 2023. And you see that there's one article on PSMA in 2021 and nothing on AI. And then in 2023, most of the most popular articles in our premier research journal, Radiology, were on AI. Actually, a radiologist, Judy Gichoya, who's an interventional radiologist, was featured in the New England Journal of Medicine, our premier journal for all of medicine, because AI is so important for how we will manage patients and especially for radiology. And there's a lot of ways that we can use it for quality control, for the initial detection of cancer, to determine whether or not a patient needs a biopsy, to plan management, and to evaluate follow-up. And then another thing that's very popular now is use of quantitative MRI. So traditionally, the images that we generate are qualitative, meaning that they present variable appearance of things, but at least the radiologist can decide is something darker or brighter. There are ways to actually measure the components within the cell. So how disordered is the image? How restricted, how small are the cells that we're looking at? How much blood flow is there? And so it allows us to actually measure something rather than just evaluate, what do I think about this? And it means that it's standardized. So if I do a scan at Cornell and my colleagues do it at UCLA, we're measuring the same thing. But the standardization that we need for measurable quantitative imaging can be very time and resource demanding, and you need to have constant quality control. And there's a question about if it takes more effort, are we going to be compensated for it? That's a consideration we have for all of our imaging. Generally, though, because we think that it will provide more value to our patients, it's something that we want to pursue. And so this is just an example of texture feature analysis. So these are the T2-weighted images that I was showing you earlier. These are qualitative images, but we're able to analyze them by looking at things like how much variability is there within a region of the image, how fast do the images vary, how strongly do they vary, and so that's kind of the difference between entropy and energy. And you can see that with the entropy images, we're not really seeing any difference between the pre and post-treatment imaging, but energy shows a marked difference. We're still learning how to apply this, but I think you're going to see more quantitative imaging. And so we want to incorporate all of these components, artificial intelligence, new pulse sequences, PSMA, quantitative imaging, to provide a map for how we can manage our patients. But still, training and qualification is still very important. Even for standard MRI, we see a lot of interest from practicing radiologists to learn the technique and to reinforce their techniques. We also want to train surgeons and radiation oncologists so that they can incorporate these things. So, Mac Roach was talking about, he doesn't see a lot of value in the MR-guided LINAC system. That's because he understands how to read the MRI. He can use that information and incorporate it into his CT-guided planning. And we need to train more radiation oncologists to be able to do this. There's an American College of Radiology accreditation system that should qualify centers as being experts in MRI. And then quality assurance is going to be very important. And I just put up some different training programs that we had, which are worldwide now. That's kind of a brief overview of where we are and where we're going. Obviously, I have a lot of colleagues to thank. This isn't a one-man operation. So these are colleagues of mine from Cornell, from sites all across the world, and especially Mark and Mark for allowing me to speak to you today. Thank you.
All right. Let's bring up my first slide. I just wanted you to go through this really quickly because with an MRI, there's all these different advertisements about what can I have, what can I not? Can I have a tattoo? I just thought this was a great, quick overview. And then when you kind of go over what you can and can't have when you're getting an MRI of the prostate or whatnot, I want to go through some other things in terms of rules when getting an MRI, if you don't mind.
Sure.
And what I mean, so I'm going to set you up to give this quick analysis is my bladder got to be full or empty? And then we're going to talk about bleeding in the prostate and waiting on a biopsy. We'll talk about diet. We'll talk about, it's important that people understand if people have metal in or near the prostate with a BPH procedure, does it run into a problem? So can you just comment on this and I can help fill in with you?
So this is actually a great introduction to why quality is so important. So we want the patient to be comfortable for the 15 minutes, half an hour they're in the scanner. So we usually have patients try to void immediately before they're scanned. And what that means is the bladder is going to fill during the scan. For the prostate, that doesn't generally cause much of a problem. Now for PSMA PET, that will mean that the image on the PET scan and the image on the CT scan may look different. However, for bladder cancer, it's very different. We need to have the adequate amount of distension of the bladder. In terms of bleeding, one of the other nice things about the NCCN recommending MR before you get a biopsy is we don't see this very much anymore. We do generally want to wait at least 4 weeks after a biopsy because the biopsy causes bleeding, and so we see that, but it also causes inflammation. And that can be very confusing because it can hide cancers. So we like to wait at least 4 weeks, and ideally 6 weeks after a biopsy. So diet actually may be the most important thing. We recommend a low residue diet, which is all the things that all your doctors tell you don't eat. This is not going to please Dr. Moyad very much. But
it's got to be done.
Yeah, but for a couple days, eat very little fiber, so like grilled cheese and French fries, those are fine. And then go back to
No wonder everybody's getting MRIs. Now
right.
I figured it out.
But then you have to go back to eating what Dr. Moyad says. Exercise probably doesn't make a big difference. Obviously, we want you to exercise and be healthy. As long as you can lay still in the scanner, that's all that really matters. However, metal is a big issue. So when you have an MRI, we have a screening form. And we try to list all the things that people might have. So tattoos, generally not an issue depending on where you got the tattoo. There are some sites outside of the United States that use iron-based ink. And the main risk there is that the magnetic field can actually cause it to heat. The good news is that you'll feel that, and so you can let us know that it's heating up. Also, piercings, you want to let your radiologist know about the piercings and remove them, because those can also heat, and depending on what's being pierced, you definitely don't want that. Probably the hardest thing for us is shrapnel, because generally people don't know what that shrapnel came from, and some shrapnel is not MR compatible. But for a lot of these other things, so it used to be that we couldn't scan any pacemakers. Now a lot of pacemakers are MR compatible. Some other implanted electronic devices can be made MR compatible. So probably the most important thing is, if you have an implanted electronic device, get the specific name of that device and bring it with you to your MR scanner, or call ahead of time so that we can research how to protocol the scan. In terms of an open scanner, our scanners are open at both ends, so they're open scanners. The ones that are like C-shaped, those just can't get enough power to image the prostate very well, so we don't recommend a conventional open scanner. In terms of sexual activity, we do recommend that patients try to refrain from activity for 2 days ahead of time, and that's because the seminal vesicles, as I mentioned, are a common site for spread, and without activity, they sort of fill with the normal amount of fluid, and then we can see better whether or not there's any suspicious areas. If they've been drained, then they look like little dark things, and it's much harder for us to know if there's been spread to them. And then some yoga attire does have metal in it. It's better to wear what the kind people at your MR scanner give you to wear in the scanner.
That was really good. I haven't talked to him in a year. He had no idea that was coming up. So let me go through that. So most of this stuff is allowed. So so no sexual activity 48 hours before, 2 days before. So no ejaculations.
That's what we recommend.
Okay. Would you recommend that strongly or kind of strongly?
I would like to think that for having one scan a year, you can go for 2 days, but everybody's different.
Well, maybe you can. No, I'm kidding. No, but I mean, how important? I mean, I'm sure it's happened when the guy said, "This is a lot to think about." Yeah. I go, "Oh, well, I had an ejaculation yesterday," and will you not do the scan? Or
So I have had patients call me in a panic that said, "Oh, it just happened." And it does. If we know, so what will happen in that case is generally we'll describe the seminal vesicles. Sometimes they look normal. Sometimes they fill back up and everything's fine. Sometimes they look drained, and we'll say the seminal vesicles look atrophic, which is the term that we use when they're shrunken. And then we'll say, whether or not we feel confident that we can exclude something there. And sometimes we can still be fairly confident, but there's a small risk that we'll just say we can't tell. If it is early in the process and the cancer is unlikely to be metastatic, then it probably doesn't matter. If it's late in the process and there's going to be a PSMA PET anyway, then just knowing where they are and correlating that with the PSMA PET largely makes up for it. But obviously you want the best scan you can get.
This is really important. So you ideally like to wait 6 weeks after a biopsy to do an MRI. So that's a more hard, fast rule? Because people obviously are in a hurry. They want to see what's going on. So would you say 6 weeks is your dream situation?
Yes.
Okay.
So hopefully one of the things you will take from the excellent Dr. Roach's presentation is that it's better to be right than fast. And so I had a colleague at UCLA who is actually on a number of the slides that Dr. Roach presented, a world-renowned expert in surgery. And he was also on a lot of our publications from UCLA looking at MRI. He was probably the main driver. And so if he said, I want this MRI done, we'd just say, okay, you know. And sometimes we'd say, yeah, I can't tell if there's cancer in the prostate or not, or even if it's, going to the edge or not, because there's so much inflammation. Usually we could tell, but you can't predict that until they're in the scanner.
And how concerning is it now? Because this came out a few years ago about metal in the prostate, like people that had urolift procedures. Is this something you can work around, or how do you? Because there are a lot of men who come to this conference who've had that procedure.
Yeah.
Which is essentially there's a little piece of metal there in the prostate.
Metal that lifts the urethra up. It's very effective clinically. It will prevent us from evaluating about 1/4 to 1/2 of the prostate, depending on its size. So we can't see anything. It distorts the magnetic field.
So then what do you do? Do you suggest a different imaging test?
So there are a few options. You can do systematic biopsies anyway. So we still do just biopsies, and the system to do the systematic biopsies is better now. We can mathematically optimize where we take them, but it is not based on seeing something suspicious. We can do PSMA PET. The presence of metal can distort the image on PET a little bit, but not nearly as much as it does on MR.
Excellent. So can we go back to the ejaculation thing?
Yeah.
No, I'm kidding. I don't see your reaction. Sorry. It's late. We get tired. All right. Let's go to, so I think we covered everything that might impact an MRI or not. And let's go to my next slide. All right. I know that you covered this, but I'm looking for a more definitive answer. Because I don't think anyone is taking a chance here. And we try to make people take a chance, and just even if you have to predict.
Yeah.
You talk to one guy, he says, I didn't have contrast, I'm glad. Another guy goes, I had contrast, who cares? Next guy says, I asked for contrast. Shakespeare said to contrast or not to contrast. That is the question. So can you just give us a quick overview? I mean, does it help that much that I should just get contrast? I mean, I want to make sure I don't have a PIRADS 5. I want to make sure there's not is it somehow limiting my scan if I don't accept contrast? That's what I'm trying to find out.
The good news is for initial detection and for men on active surveillance, so untreated prostate cancer, non-contrast MRI is probably as good as contrast-enhanced MRI in experienced hands. So if you want to go for that, find a center that has people that are dedicated to prostate imaging. For the post-treatment phase, unfortunately, the treatment makes it confusing enough that often the contrast-enhanced images are the only ones that give us useful information.
Ooh, that's good stuff. So pre, you're feeling okay. Post, you'd really like to use the contrast.
Yes.
Thank you. Thank you. All right, I wrote this as a kind of a joke. See how small the lettering is?
Yes.
You always said that about 20% are, and even Claude's talked about this, the MRI invisible, you can't find them. So where are we going with this? I mean, I don't like the fact that 20% of cancers that it could be significant are invisible, but Dr. Claude said that you shouldn't have to worry too much about those. Those tend to be normal. What's your take on it? Is this really a right statistic that 20%, they're invisible, you can't find them on MRI?
Well, I'm on a publication that says that, so I have to say yes. So the publication in question is a case where men that went to surgery, we systematically sliced the prostate and found all of the tumors, and we looked at the report of the MRI and found where did we say there was cancer, and at least 20% of significant cancers were not prospectively reported. And this was at a time where the MRI was being done to plan surgery. And so part of what we were looking at is this a cancer that's going to affect the surgery? And if we found one big cancer that was going to determine how the surgery was going to be done, we didn't want to report all the little tumors that were going to be taken out anyway and might confuse the issue. So we don't want the surgeon to get confused about, well, wait, which cancer is it that I need to watch out for when I'm doing the surgery? So that's part of it. But there are cancers that we just cannot see on MRI. And some of them are very small, and the idea is, well, we're going to follow the PSA. If it doesn't go up, then that's not an aggressive cancer, and we don't have to worry anyway. And if it starts to go up, we'll repeat the MR. And then even if it was very small and was hard to detect on the original, we can compare, and that gives us twice as much information to be able to detect it.
Okay.
So it should be concerning, but it shouldn't be concerning enough that you think that there's not value to the MR. The MR will still find almost all of the ones that are actionable, and when it doesn't, there's time to find it with the next time point.
Does your group still do second opinions on MRI if someone's not sure, they're stuck in a PIRADS 3, or there's something equivocal or ambiguous? You kind of give me that look. I think I know that you don't like to do but I still don't understand why there's not more advertising on second opinion readings. What's your thought?
So part of it is UCLA had a system for this. It wasn't really well established. Cornell specifically does not allow us to do second opinions for patients from outside of Cornell. And we don't have a system to process them. But we are merging with pathology, so we're going to be the Department of Diagnostic Medicine because we're both involved in diagnosis, and they have a system to do this, so hopefully we'll be able to do that. That being said, one of the things I mentioned was AI. AI is basically an expert radiologist that will miss things and will misdiagnose things, but very rarely. And so a human radiologist plus AI performs as well as any expert human radiologist.
And I can get that all over the place now?
It's growing. We're actually going to be part of a clinical trial with a company from England. There are a number of sites that will purport to use AI for prostate cancer detection. The concern there is, are they only using AI?
Yeah, well, I just think someone's got to pick up the slack on more second opinion centers. You can go to all these second opinion pathologists. Why can't you go to second opinion MRI people? I just don't get it. Maybe you can explain it tomorrow.
Part of it, yeah. Part of it is the quality for the MR varies from site to site.
Yeah.
So for instance, NYU, world-class institution, very high quality, but their protocol is very different than ours, and it's a lot of effort to figure out what did they really mean.
Next slide. This always perplexes me. It's so important to know the size of your prostate.
Yeah.
It's part of active surveillance. It's part of the decision-making process on PSA density.
Yeah.
So can you solve this dilemma? We know that a finger in the rectum is not a good predictor of the size of the prostate, and that was actually used for the longest time.
Yeah.
So which one's better at showing you the size of your prostate? MRI, PET CT, ultrasound? Which imaging test can I feel comfortable when they report the size of my prostate, which I'm going to use in a calculation to decide whether or not I might stay on active surveillance or maybe some other issue going on? Where can I feel confidence that the size of my prostate is accurate?
So MR is the best because it has the best tissue contrast.
MR is the best. MR is the best.
MR is the best. Transrectal ultrasound technically has better resolution, but it distorts the prostate because you have a big foreign object in the rectum. So our secondary choice is transabdominal ultrasound. We can see the prostate through the bladder. It's not distorted. It is much more comfortable than an indirect ultrasound, I am told. I have not had one. And hopefully with modern technology, I won't need one, but we'll see. But my colleagues in urology do indirect ultrasound all the time and keep trying to order that for measuring the prostate. And I keep trying to tell them, your patients will be much happier if we can get you a better measurement without the indirect probe.
So do all your MRIs report the size of the prostate, just standard? Okay.
Yeah, that's part of PIRADS.
Okay, that's awesome. This slide essentially implies that the higher the PSA, the greater the chance that the PET CT picks up on a cancer that's come back. Right?
Yes.
Then let's go to the next slide. So this slide implies, though, that with a PET CT scan, sometimes there's what's called a halo effect because you're excreting this through the bladder. It creates this halo, and if there's something close to the bladder that's a tumor, it could get missed or obscured, right?
Yes.
So my question comes down to, it's a two-part question.
Yeah.
If a PET CT is better at picking up cancer as the PSA gets higher, let's say someone's had surgery, but they don't pick it up at a 0.2 or 0.5, the patient is left with the dilemma of the radiation oncologist saying, listen, we need to radiate now. We don't want to wait. So how do you solve this? Do you, if someone's negative on a PET CT at 0.3, 0.4, 0.5, do you get excited about waiting till 0.6, 0.7, 0.8 and having them redo it? I mean, that's what I want your comment on.
Yes. So it's worthwhile to interrogate the PET CT and say, well, okay, we didn't find something that looks like recurrence. Is there anything that could be generating PSA? And one thing that can help in that case is MR. What we sometimes see is some residual seminal vesicle material. And MR is quite good at determining whether or not there's any residual seminal vesicle material and whether or not there's tumor in it. And if you ask our colleagues in surgery, they never leave any seminal vesicle material behind. But if you ask my colleagues in radiology, we see it often enough. And so that can provide an explanation. It may not be enough to assuage the radiation oncologist to not recommend radiation, but it may be enough to use shared decision making to maybe see if the PSA level's off or if it continues to rise.
So ask for an MR.
Yeah, MR can be very useful in the situation where PSMA is negative and there is a rising PSA.
Okay. Go to my next slide before we finish up. I didn't know if you, I haven't talked to you. I didn't know if you even want to comment on, there's people are just starting to talk about this micro ultrasound movement. Do you have anything? I know it's dirt cheap. I know it's a real-time image, means you're looking at things as they're happening. I know there's no radiation associated, but you know, there's probably some catches here we don't know about. Do you want to comment on this, or is that something you want to talk about tomorrow morning?
I can comment briefly. So it's a technique developed by a company in Canada. It's obviously much cheaper. Ultrasound is much cheaper and much more energy efficient than MR. MR has about 100 times the pollution footprint of ultrasound. So it's potentially simpler. It does use an endorectal ultrasound, so it's a little more uncomfortable. But it's very what we call operator dependent. So the person doing the ultrasound or reading the ultrasound has to be experienced with how to interpret it. And the system for assessing it, which is standardized, is not as clear and straightforward as PIRADS. So I think it's a good idea to consider starting with it if they will use it to guide the biopsy. And if that gives them enough information to manage the patient, that might be enough. But MR is still, hands down, better in terms of determining exactly where the tumor is, the size of the tumor, and the stage.
I talked to a urologist friend of mine in Phoenix the other day. He told me something I didn't know, and I don't know if you have a comment on this. He said people are talking about the cost of MR and all this, it's always expensive, but he said what's happening in the Phoenix area is the price has been coming down so much that now he has a lot of patients paying, well, they used to be $1,000, $2,000, they're paying a couple $100, $400 or $500. Is that true? Is that really coming down that fast in price?
So the cost of an MR is, well, how much do you want to pay? So the cost of MR can come down depending on how well you negotiate with different insurance payers and what Medicare decided this year and how long the scan is and whether or not you're billing for with contrast or without contrast only. So you can find a scan for only a few $100s. The main thing you want to consider, though, is it going to be good enough? So we see scans. So one thing that insurance companies will do is you'll get an order for an MR, you'll schedule it at UCLA or at USC, and they'll say, well, but the guy down the street, we'll pay you $50 if you go to her instead. And you don't really know what quality scan you'll get, but that center is charging half as much. And so the insurance company's like, well, I'll save some money in the short run.
Yeah, so you gotta, You got to do some some interpreting, interrogating actually. But
So call UCLA and say, hey, will you do the price match guarantee?
I like that. You think they really might budge?
Yeah, well, they don't hire me anymore, so I can say what I want.
So I have about 20 other questions, but we're going to save those from 8 to 10. People know I'm going to throw out some of those, but I can't let you leave here without a couple of quick thoughts. Okay, what's the more important question I can ask you today? I knew you before you suddenly took up this vegan movement, right?
Yeah.
And you still are doing that?
Yeah.
And you're still very happily doing that, which is great. So I thought we would play my new game called Vegan or Not Vegan.
Fair enough.
Okay?
Yes.
This is kind of a greater example leading up to your gift.
Yes.
And leading up to a gift for the audience. Can we bring up the next slide? Kale, vegan or not vegan?
Very vegan.
Okay. Next slide. Pringles original.
Probably vegan.
Vegan is correct. Next slide.
Oh, yeah, vegan.
It's true. See, so this is where I get excited about the movement.
Yeah.
Right?
Yeah.
I mean, that's good. That's a good answer, and it shows you why you got to really do your homework, because obviously.
It also shows you what little natural ingredients there are in Oreos.
Exactly. So that's exactly true. You got 3 out of 3, and now let's go for the last one. Swedish fish. Yummy, fabulous, and you know why I did this? Because I know that you speak Swedish.
Yeah.
How about that?
Det stämmer.
Yeah.
Unfortunately,
God bless you.
thank you. Swedish fish contain gelatin, and gelatin is derived from pig bones.
But I heard some of the Swedish fish now, they're taking the gelatin out, so I thought that was enough of a reason to celebrate your Swedish heritage and the fact that you speak Swedish, and if the group can come out, like we were about to give you a car, remember that? And instead we gave you a bar, and now you get a Swedish fish, you get a Swedish fish, you get a Swedish fish, and for those of you who don't want to eat Swedish fish, we have a separate group bag of baby carrots. You get a baby carrot, you get a baby carrot. We know that Daniel gets baby carrots. He's not having Swedish fish.
No.
So we want to make sure that you have a little bit of food, a little bit of sugar, a little bit of energy left for our last speaker, because it's an important item he's going to cover. And in the meantime, while they're giving out the Swedish fish in your honor, and the baby carrots, if you don't approve of the Swedish fish, we got you your gift this year that says, it's a cup for your office that says, Kale, yeah, I'm vegan. Here you go. Let's give him a round of applause. He's always awesome. Awesome, Daniel. Awesome.
Thank you.